Hi, hello, welcome. Morphologically, cranial nerves can be classified into three different varieties: oculomotor, trochlear, abducent, and hypoglossal nerves supply muscles derived from cranial myotomes. These are the muscles derived from cranial myotomes, occipital myotomes, and preoccipital myotome. Preoccipital myotome gives rise to muscles of extraocular group supplied by cranial nerves 3, 4, and 6. Cranial number 12 supplies occipital myotomes, which develop into muscles of tongue. Cranial nerves 5, 7, 9, 10, and 11, they supply muscles derived from branchial arches, which develop in pharyngeal arches. Cranial nerves 1, 2, and 8, they are associated with special senses. How morphologically these are classified? To understand this, we have to look at the location of nuclei of all these nerves in brainstem. Let us observe. This is brainstem showing nuclei of different cranial nerves. Observe here, this is oculomotor nerve nucleus, trochlear nerve nucleus, abducent nerve, and hypoglossal nerve. All these being general somatic efferent, they lie in line from midline to medulla. Oculomotor and trochlear, they are situated in midbrain at the level of superior colliculus and inferior colliculus. Abducent is located in pons at the level of facial colliculus. Let me discuss cranial nerve number 6, the abducent, the meaning abductor of eyeball, supplying lateral rectus. These are the learning objectives, mentioning the functional components of abducent nerve, explaining the nuclei, intracranial cores, extracranial cores and relations and distribution, mentioning few peculiarities of sixth cranial nerve and related applied anatomical aspects. Functional components of abducent nerve are general somatic efferent and general somatic afferent. General somatic efferent is to supply lateral rectus. General somatic afferent is proprioceptive fibers from lateral rectus, eventually which are given to mesencephalic nucleus of trigeminal nerve. This is transverse section of pons at the level of facial colliculus. Facial colliculus can be seen here at the dorsal aspect of the brainstem, in the floor of the fourth ventricle. The elevation of this colliculus is because of the arching fibers of facial nerve around the nucleus of abducent. Abducent nerve fibers pass forward and downwards through the medial lemniscus and through the trapezoid body, and finally they arise on the surface of the brainstem at the lower border of the pons and upper part of the pyramid of medulla. Here they arise on either sides. Once it comes out, they sharply turn upward bend and starts ascending. This picture shows the relation of abducent nerve. The related artery is inferior cerebellar artery, branch of basilar artery. Abducent nerve ascends up towards the cavernous sinus. This picture shows its course. It's coming out here at the junction of medulla and pons, ascending up on either sides of the clivus. Once it reaches the upper border of the petrous temporal bone, it again turns sharply forward into cavernous sinus. It's related to internal carotid artery in cavernous sinus. Here we can see abducent nerve taking entry into cavernous sinus. The relations of abducent nerve inside the cavernous sinus can be observed here. This is abducent nerve, just related infralateral to internal carotid artery. Abducent nerve is seen here in this picture. Leaving cavernous sinus, abducent nerve moves forward, taking exit out of the cranial cavity through superior orbital fissure into orbit. This happens through the annular ring of Zinn along with oculomotor nerve. You can see abducent nerve is coming here, taking inside the orbital cavity, and it is supplying lateral rectus. Lateral rectus is shown here, which is cut, other end is here. We can see the same in front view. See, this is lateral rectus and supplied by abducent nerve. It is supplying the lateral rectus from its bulbar surface. Let me discuss on some peculiarities of abducent nerve. Abducent nerve bends twice sharply in its course and changes its direction thrice. This is its nucleus. It is descending down and forward intraneurally. Once it comes out of the brainstem, it sharply turns upwards and forwards. This is its course. Once it reaches the upper border of the petrous temporal bone, it sharply turns forward. So this makes abducent nerve having longest intracranial course compared to any other cranial nerve. Whenever there is increased intracranial pressure, the brainstem can be pushed downwards, or medulla can be pushed downwards towards the foramen magnum. In such conditions, there is a pulling pressure which is exerted on the long course of this abducent nerve, which can cause palsy of abducent. Let us discuss few applied anatomical aspects. Palsy of abducent nerve is common in increased intracranial pressure. Paralysis causes medial squint. Here we can see this is because of unopposed action of medial rectus. Cerebrovascular damages in the lower part of the pons can result in Millard-Gubler syndrome, which involves abducent nerve, facial nerve, and also pyramidal fibers, which causes ipsilateral abducent nerve palsy, ipsilateral facial nerve palsy, and contralateral hemiplegia.